wanted to talk today about a couple of papers that have recently come out, but I think they point out what I think has been obvious to many experts, but maybe not so much to others who are just following casually, and that's the ongoing toll of COVID cases and transmission and the missed opportunities we have to mitigate that with antiviral treatment. So first off, just starting with a brief snapshot of where, excuse me, where we are today. As you can see, our total official case burden is at a relatively low point over the last year, with about 40,000 cases per day being reported, down significantly from the 800,000 cases a day that were reported in January with Omicron B1, and even significantly lower than close to 200,000 a day we were seeing during the BA2, BA4-5 surge. However, I think it's important to point out, again, we are ascertaining a relatively low number of cases compared to true cases because of low frequency of testing, and much of the testing that's done is with home antigen tests that don't get reported. And if you look at the test positivity rate, which I think is a better indicator of what true community burden is, you can see that we're at relatively high rates, similar to what we saw in the Delta peak in late summer, early fall of last year. And so if you extrapolate in terms of where that was, we were up around 160,000 cases a day at that point. And again, under ascertaining significantly there. So the reality is that true cases, we are seeing hundreds of thousands of true cases of COVID still every day in the United States. And that means well over 1 million every week, probably more like 2 million is a realistic estimate of how many cases of COVID-19 we're experiencing in the US every week. That's still a massive number, right? That's still a lot of folks who are potentially exposed to the risks of COVID infection. And those risks are not just hospitalization and death. And you can see the rates of hospitalization are still relatively high, again, much higher than they have been at the previous nadir, the summer of 2021. And deaths are still over 300 a day. But I think more concerning to me at this point are some of the other long-term consequences that we can expect from COVID infection. So the first paper I want to talk about was recently published in the British Medical Journal, the BMJ Heart Journal. It's a study that was conducted in the UK, and it looked at the UK Biobank study. So this is a study that was ongoing before COVID started. It's a longitudinal follow-up of 500,000, greater than 500,000 participants who were recruited about 12 to 15 years ago in the UK. At that time, they were aged 40 to 69. So obviously they're a little older now. And it followed these folks prospectively and identified those who had been diagnosed with COVID versus those who hadn't. And that was between essentially New Year's of 2020, so the beginning of the pandemic, and New Year's of 2021, so the first year of the pandemic in the UK. So on average, it was 141 days of prospective follow-up after COVID diagnosis, and then matched controls who were also from the biobank study. So very well characterized group and frequent follow-up to understand health events. And so you can see about 18,000 COVID cases recorded during that time, and compared with match controls about 36,000. So a 2-to-1 match. Of those 17,800 COVID cases, they had a little over 14,000 were not hospitalized, so not severe enough to warrant hospitalization. 2,700 were hospitalized with a primary diagnosis of COVID, and about 900 were hospitalized with COVID as a secondary diagnosis. This is sometimes those, hospitalized with COVID, not, from COVID type cohort that we hear talk about, and we'll get into that a little bit as we analyze this study. So there you go. 14,000 non-hospitalized, almost 3,000 hospitalized with COVID, and almost 900 hospitalized, with COVID, but not for COVID. And then again, those matched controls, and again, important to note that they match them for a variety of different characteristics, not only age, but lots of underlying health issues and demographics. So pretty well designed study. Now, this is, a group that's a bit older now, again, because it was a study that recruited initially in the late 2000s. So you can see the average age is around 65. But they do seem very well matched across all of these different, all of those different characteristics. So I think the important thing to look at is then what are the differences between the controls and the COVID cases in terms of cardiac events. So again, this is focusing on cardiac events and mortality. And you can see, first of all, a dramatic difference in incidence of things like venous thromboembolism. Those are blood clots, VTE. 13-fold higher in COVID cases versus controls, and all-cause mortality over that average of 140 days was 35 times higher in the COVID cases. And you can see across the board, all of those cardiac events are much more likely in the COVID cases versus non-COVID cases, mostly around a 5-fold increase. And again, mortality dramatically increased. That's not all explained by cardiovascular disease, and that makes sense, right? You have pneumonia and other things that cause death in acute COVID. But the reality is this cardiac death is still over 5 times as prevalent in COVID cases versus non. And this highlights that, and there you go, the rate was even higher in hospitalized cases versus non-hospitalized, 118-fold increase in cases that were hospitalized. But look at that 64-fold increase in patients who were admitted, with COVID and not for COVID. And so I'm doing air quotes if you can't see, because what this points out is that, even if COVID is not listed as your primary diagnosis, and again, it says, oh, these were incidental COVID cases. If you're admitted with a heart attack or a blood clot or something else that is not thought to be due to COVID, because again, I think the perception, even among physicians, is COVID is a pulmonary disease. The reality is COVID is most likely a significant part of the pathogenesis of what's going on. And your risk of death, if you're admitted even with COVID and not for COVID, is 64 times higher than folks who do not have COVID. So I think this points out that, COVID has serious consequences outside of the lungs, including cardiovascular disease. And when you look, it's not only the risk that is accrued acutely within the first 30 days. You can see those blue bars on the right are incidences of these events related to COVID. Red bars are in controls. I should say the blue bars are from COVID cases. The red bars are in controls. Remember, there's twice as many controls as there are cases. So the blue bars should be twice as high to correct for proportion. And so you can see that the risk of these events not only occurs acutely in the first 50 days with a COVID diagnosis, but extends out really up to 200 days or more after the event. And you can see on the left, these are plots of the hazard ratio. So how much more how much higher is the ratio of the risk of event in COVID versus controls? And you can see mortality again way up there between 30 and 40, but almost all of those cardiac events have a significant increase. Actually, all of them except, all of them actually have a significant increase over the controls as for COVID patients compared to non. And so again, this indicates that people who have a diagnosis of COVID have increased incidence of cardiovascular events in addition to pulmonary events. Those increased events put them at much higher risk of severe disease and death. And that extends well beyond the acute phase of COVID. And we've seen from other studies that effect lasts for a year or more. If you remember the VA study of VA data of hundreds of thousands of veterans, showing again the cardiovascular events even a year out are much higher among people who are diagnosed with COVID versus not. And this last table kind of highlights that. So even they analyzed separately events within the first 30 days of COVID diagnosis compared to the events after 30 days. And again, still a dramatically higher rate of heart failure, of atrial fibrillation, of venous thromboembolism in those COVID cases compared to those who did not have a diagnosis of COVID. Again, a 4 times higher rate of COVID or of venous thromboembolism in COVID versus non. And then again, all-cause mortality, about a 10-fold higher rate of death even after 30 days of COVID diagnosis. So again, it's not just the acute COVID that kills you or causes long-lasting problems. It's the health effects that can occur weeks and months after a diagnosis of COVID that still have an impact on the population. And that is not well measured, right? You don't see that in the New York Times of, hospitalizations or health events months after COVID diagnosis, right? There's no graph that we're seeing that that gives us those data, but all of the studies that, most of the well-conducted studies, certainly that have looked at post-COVID health events, show a similar type of phenomenon. So this is the iceberg, again, that's under the water that we don't see. But the long-term dramatic health effects of what we are experiencing with COVID and these millions of cases in the US a week, we're still accruing, we're still accumulating that. So the second study to talk about is one that was just published in medRxiv as a preprint. So again, not yet peer-reviewed, but this is from that group from the VA. So Ziad Ali is the lead author again, and he's been, these other two have been behind most of these large data analysis papers from the VA database looking at long-term consequences of COVID. This paper looks specifically at the effect of treatment with nirmatrelvir, or that is Paxlovid again. So Paxlovid is a combination of nirmatrelvir or nirmatrelvir, however you pronounce it, and ritonavir. And that Paxlovid drug is obviously the mainstay of outpatient treatment that we use now for COVID. And this data analysis from the VA looked at patients treated with Paxlovid versus those not. I'll point out that the studies that have been published previously by these folks have all gone to peer-reviewed journals in very high-profile elite journals and have all passed peer review. So I imagine that this one will as well. These are really well done studies that these guys have done at the VA. So this study looked at veterans diagnosed with COVID between March 1st and June 30th of this year, obviously when Paxlovid was readily available in the US. And it looked at patients who were outpatients on the first day of the positive test. Again, that's a qualifying factor of the Paxlovid treatment. It is for outpatients. That's how its EUA was approved. And then these patients had at least one risk factor for progression to severe disease. Again, part of the EUA conditions for treatment. And it looks at patients who were treated within 5 days of the positive test. And so it ended up with about 9,200 of those patients treated with Paxlovid, and then compared it to matched controls who were also COVID positive, not hospitalized at the time, same risk factor profile, but for some reason did not receive Paxlovid. So you can see that a couple of things to note on the chart. First of all, across the board, those groups were relatively comparable, the Paxlovid treatment group versus the control group. Second of all, again, because this is a VA study, we know that this population will be predominantly male and older, right? So about 87, 88% male and average age about 65. So we do need to take this with a grain of salt if we are projecting this to other populations. However, this group is certainly at higher risk of progression than others, but we can extrapolate at least in terms of how it's impacting the risk in other populations. And so the primary outcome was development of or diagnosis of long COVID symptoms, which they defined as only having one of a 12 symptom or 12 characteristic group of sequelae of SARS-CoV-2 infection. This can differ from other diagnoses or other qualifications of PASC or long COVID, right? Some studies have required at least 2, some studies have required at least 3. So again, there's no formal definition still of long COVID now, which allows us to normalize across all these studies, but it is identifying at least one of these characteristics that's been associated with long COVID in other studies. And so what you see here is not surprising, I don't think, but maybe revealing to those who have advocated for limited use of Paxlovid. There is a significant reduction, not only in long COVID or PASC, right? That's post-acute sequelae of COVID-19, but also a significant reduction in death, a significant reduction in hospitalization, and obviously the combined death and hospitalization in patients who were treated with Paxlovid versus those who weren't. And you can see the absolute risk reduction that's, out of 100 patients, what is the absolute risk reduction that treatment with Paxlovid gave you? So it's 2 out of 100 in reducing the long COVID, and over 1 out of 100 for hospitalization. So a pretty significant number, even in absolute terms. And if you look at the Kaplan-Meier curves here, you can see this is for development of long COVID. You can see that this is not just an effect that is present in the first couple of weeks after the diagnosis of COVID. Again, this even starts after 30 days. And you can see that the incidence of long COVID post-sequelae symptoms in controls is dramatically higher and continues to separate from the Paxlovid group over the course of 2 months after 30 days. So 3 months after diagnosis is more appropriately put. So again, the impact of Paxlovid is not only in acute recovery, but it lasts for 3 months in terms of lower rate of long COVID developing in those veterans. That's also true for death, right? So these are rates of death after 30 days, right? So at 30 days, calling them even, and then looking at deaths that occur over the 2 months after that. And you can see that patients treated with Paxlovid have a much lower rate of death, and that much lower rate continues to divide and separate even at 3 months, and the same thing for hospitalization, right? So this reflects back on the previous study that the effects of COVID are not just acute. They're not just in the first couple of weeks while you're in the hospital or while you're sick. But even when you've quote unquote recovered from acute COVID, you are still suffering consequences of your COVID infection that is the result of immune dysregulation, inflammatory cascades that affect potentially the endothelium, blood vessels, clotting, et cetera. So all of those things that lead to increased cardiovascular events that we saw with the last study lead to higher rates of hospitalization and death long term after acute COVID, and treatment of acute COVID reduces the incidence of those bad outcomes. So the results of the study kind of summarized a 26% reduction in long COVID, almost a 50% reduction in post-acute death, right? That's death that occurs after 30 days, and a 30% reduction in post-acute hospitalization, again, hospitalization that occurred after 30 days. This effect, and this is important, this effect was present in people who were unvaccinated and people who were vaccinated and people who were boosted, right? So you'll see a lot of physicians and so-called experts will say, well, the effect of Paxlovid's only been proven in the unvaccinated. So people who are vaccinated, and especially those who are boosted, are low risk, and there's no reason to treat them. That's wrong, right? This study shows that there's statistically significant effect in people who are vaccinated and people who are boosted. And it's also true in people who've had reinfection, right? It's not just your first COVID infection. It's subsequent infections that also carry risk, and treatment of those infections with Paxlovid reduces that risk. And again, I'll point out that this group from the VA are the ones who really have the the most convincing study that indicate risk with reinfection is still significant and puts you at much higher risk of developing all sorts of severe long-term consequences, including death, right? That was a study that came out maybe 5 or 6 months ago. Also important to point out that only about 16% of the veterans who were eligible to receive Paxlovid, right? So veterans who had a risk factor and who were eligible for treatment, only 16% of them actually received treatment. And the VA is, a system where for things like this, their performance is often better than in other health systems. And these data are pretty consistent, or actually a little better than what some other studies have shown, which are mostly below 10% of eligible people are getting treatment. So this shows that we're leaving a lot of these potential benefits on the table, right? We are not treating enough people with Paxlovid, and that means we're suffering all of these long-term consequences that these two studies have pointed out. And that's the obvious thing to me, is that, first of all, we are missing much of the iceberg that's below the water. And those are the longer term health consequences of COVID infection, not necessarily whether you die or end up in the hospital within a couple of weeks of your diagnosis when you're officially counted as a COVID casualty, but what's happening 2 and 3 and 6 months later, right? And what are we doing to prevent those things from happening? Well, we're certainly not treating many people with Paxlovid, which has a dramatic impact in your odds of developing any of these later consequences. So with that, I'll end and turn it back to you, Dasi.